Okay, let's start with, who do we have? Kate?
Yeah. Hello. So my question, I guess, will be for GI related. Have you noticed, is malabsorption a common problem? Because even though my son is on a formula that's supposed to have everything he needs and takes the right number of bottles, all of his vitamin levels, ferritin levels are like so low, and it's like he's not absorbing everything. And sometimes feels the same way with medicine. So I'm just curious if, like, especially our patients that are tube fed, if that's just to be expected, and if there's like a formula, or I don't know.
Yeah, so that's a great question. So no, it is not to be expected. In theory, and I shouldn't even say in theory, these formulas are designed in order to provide all of the nutrition that patients need. I am very fortunate that I have a dietitian who sees all of my patients with me, all my FOXG1 Rett syndrome patients with me, she does a lot of math and calculations to ensure just because you're on a formula that is theoretically a full supplement, depending on your child and how much they take, they may still not be getting exactly what they need. And so we do often have to supplement things like calcium and even potassium and other things like that. When I start thinking about malabsorption, it's not a super common issue with FOXG1. That is not to say that your child does not have that issue. Generally, we will see diarrhea, and that is usually our body's sign that it is not able to absorb the things that it needs. Absent of diarrhea, I really start thinking more of the body is just utilizing those things faster than we're giving it to the patient, and we just need to supplement higher. Sometimes changing formulas do have different amounts of different things, and so depending on what your child is deficient in, sometimes switching to a formula that's going to be a little bit more replete with that can certainly help. But it is not an expectation that children on formula are not going to get what they need. The goal of these formulas is to truly take the place of a complete diet. I hope that answers your question.
Do you have a favorite for G-Tube Fed? I know maybe you're not sponsored here, but do you have, we talk about it all the time. There's Kate Farms. I just learned about Nourish. Do they really cover everything our children need? And what do you usually prescribe?
Yeah, so I will be totally honest, I don't have a favorite because every patient is so different. Some patients need a peptide-based formula, which is like a very broken down formula. Other patients don't. Some patients do really poorly with dairy. Other patients don't. Some patients do better with what's called a low osmolarity formula, so a formula that isn't as dense. Other patients do totally fine with the really dense formula, so they don't need as much volume. And so it really varies by the patient, and not just the patient, but what's going on with the patient. Often when we start formulas, it's in addition to food, and so maybe they don't need something that's going to replace 100% of their dietary intake. Kate Farms is great. I have a lot of patients who do very well on it, but general Pediasure works for some people, so it really depends on the patient. And some families really want a vegetarian formula, really want a plant-based protein formula, really feel that organic formula is important, and so we really want to work within the realm of what's important to that family as well. And so thankfully, there are a lot of options, and so we can kind of work depending on what works best. They can absolutely change over time. Yeah, the needs do change over time with the person. Absolutely.
Courtney?
Who drives the changes in formula? Is it your dietitian?
Sometimes it's the family.
Yeah.
Sometimes it's the family. In fact, I would say often, it's the family in that they're telling us that this formula isn't working for some reason. And so with that, the dietitian and I will look through and kind of decide which other formula might be better.
But I think that's a great point, that when you see a GI doctor, that there's also a dietitian working with the GI doctor, which is not always the case. So that's really a great point. Yeah.
I have a question for Dr. Benke about sleep. I spent the last month with developmental pediatricians who see a lot of patients with autism, and I've been seeing them use doxepin in their kids, which I hadn't previously seen. It's an old tricyclic. Do you see any of that, and have you seen any effect?
Yeah, it is on the list of different meds to use. It's not one that I've used that much. I think that the side effect profile, may not be ideal for some people, but it is on the list that a lot of people will use it. Is it working? Have you started it?
Okay. Josie's on it. But, and actually, we were told the side effect is that she's going to sleep. So she's been on it, but if there's other side effects that we're not aware of, I'd love to learn. We'll talk. But it works. So I will say Josie sleeps well. Yeah.
Maybe one quick one from the virtual audience, which is there potential for anti-epileptic medications to potentially slow down progress? I think they're talking about developmental progress here.
You want to answer that one, Amanda?
So that's a really loaded question. Of course, it's top of mind for a lot of people. Part of the issue is polypharmacy is when you're on too many meds at once, right? And you get, especially if they have the same mechanism, and so if you're taking several sodium channel blockers, you get those kind of side effects, which may include fatigue and so on. And then that, of course, will make it harder for your child to learn and develop. So, of course, there's impact of that. I was trying to underscore in the talk a little bit that there is more movement towards looking at positive behavioral impacts of drugs, including, memory, cognition, executive function, and regulation type things, which also support overall development. And so, of course, bringing the seizure count down helps, and then in addition, you want things that have positive data regarding that. So I hope I answered your question. Yeah.
I think the main point you're making is sometimes when children are on too many medications, there's, it's hard to tell what that's going to do, and that there are side effects.
You do have to have somebody who's thinking rationally about the choices of meds that you're on, and not just kind of loading you on things that they're familiar with or that is cheaper or easier to prescribe, whatnot. To have different mechanisms involved minimizes the chance of having particular side effects that might be common to, drugs that have similar mechanisms.
Yeah, and in our community, we talk about these known side effects often. A lot of people don't like Onfi because they think their child is just a shell of themselves when they're on Onfi. There's Keppra Rage that we talk about. So then you take, then you're on 4 of them at once. So, it's scary for a parent. You're like, what are all these drugs? But at the end of the day, it's the seizures that are the scariest part. So I think that's what that question was. And
by and large, we are trying to, have new medications that are more specific to target the thing you want to target, leave alone the thing you want to leave alone, and have less, of the fatigue and all of these things, which still remain a problem. So, yeah.
Our daughter luckily she's starting to eat pretty well from a spoon. Time to time, a couple meals a day that are tiny, but we need to keep giving her formula too. But she's at that age where it's not infant formula. I don't think she should be eating. It's probably something different, and we don't know what that is, and we don't really have any advice that we've received. But what would you suggest for types of formula that are for old, year and a half and older to supplement regular food?
Yeah. The magic of off and on. Okay, that's a great question. So yes, there are specific infant formulas that are designed in a special way for the needs of an infant. And then once a child gets over the age, these are rough guidelines, over the age of 1. Some of that depends on the size of the child. Children who don't grow well, we often will keep them on infant formula till 18 months or something like that. But once they've reached kind of a certain size, a certain age, we do want to transition them to toddler formulas. And so kind of the classic is going from like Infamil, I'm just using an example. I am again not paid by anybody. But Infamil as, let's say, your infant formula, and then switching over to Pediasure once you hit that kind of 1.5 year. There are toddler formulas that aren't necessarily needed. You can kind of go on to a children's formula once you're kind of over that infant stage, and that should be fine, especially when it's supplemental and not the full 100%. But yeah, I think that generally I like to transition my patients, by 15, 18 months, unless they're very, very petite for some reason, just really struggling to grow. But generally, yes, it will benefit as far as providing complete nutrition for that older child once they get to about between 12 and 18 months.
So our son Tristan, this is for all 3 of you, our son Tristan, still to this day, we haven't received a formal diagnosis for epilepsy, because in the moment when we think he's having a seizure, it's also presenting as a muscle disorder. An example is he goes into a full sort of body crunch. And we have also noticed a pattern where if he's having, so all of his seizures happen during the middle of the night, at like between 3 a.m. and 6 a.m. It's always around the same time. If he needs to have a bowel movement, if he needs to pee, he's having a seizure. The moment he's able to have a bowel movement or pee, he comes right out of the seizure. And so we are currently on Keppra and clobazam. He's stable. However, we're still trying to determine, our neurology team are still trying to determine, is it epilepsy or is it a muscle disorder, and what's the connection with the whole gut and brain piece. So if you can talk a little bit more about that, that'll be helpful.
How old is he?
4 years old.
So I think we're both going to say is that have any of these been captured when he's been hooked up to an EEG? So sometimes you need more than one EEG. I have a bad joke. How many child neurologists does it take to change a light bulb? Only one, but it takes several visits. So he probably needs another EEG. And I think my question always is yes, spells might have been captured, but do you think it was the spell? And if it wasn't captured, it wasn't captured. And so he needs more monitoring to try to capture them. Because, if these aren't seizures, then does he really need to be on meds? What are we treating? Anything else?
I entirely agree.
I'll just comment on that. I don't know if he's on treatment for constipation or gas pain, but I think I would probably have him seen, but you can even talk to your PCP about it, but if there's a gastroenterologist in the area, it might be beneficial just to take that off the table. I will often say, if there is a possibility that he's having pain trying to pass a bowel movement and that is spiraling him into either a movement disorder or a seizure or whatever it is, let's just get rid of the constipation. That way that's at least off the table, because even if it is seizures being brought on by severe constipation, once constipation's gone, maybe the seizures are no longer an issue. And I don't know that that's what's happening, but I think that if you're noticing, I can't help with the urine problem unless it's because he's constipated, and you can have urinary retention from constipation. And so I think that if there's something in your, parent mind saying this is tied to his bowel movements, I think getting that kind of looked at is a good idea.
Wow. Are you near Boston Children's? Okay, great. Yeah. Yeah, it's a good place to go. Yeah. Any other questions here?
Sure. So kind of returning back to side effects and concerns that parents have, I know many of the children in this room and hundreds of the FOXG1 children are on Miralax, and you mentioned it in your presentation. Knowing that it's being used off-label but not technically approved for children under 17 or for long-term use, do you know if there's any studies to be done to confirm its safety in children?
Yeah, so there have been studies in children as young as 6 months for Miralax, and so that's why we feel quite comfortable using it. If you Google's a scary place, but if you Google, you will find families who will report that their children have almost like psychiatric side effects from Miralax, or and that To me, if a family reports it, it's real. I have had a couple of parents who tell me when their child's on Miralax, they just act wild, and so we avoid it. And I've had 2 patients my entire career, but I can't tell them that they're not telling me the truth. Like if they tell me like, I give my child this medicine and this happens, then I'm going to take it seriously. I have also, and this is where some thoughts have been that potentially it is more a factor of loss of control that causes some children to behave that way. And as an example, I have a patient, she does not have FOXG1, but she does have seizures. She was incredibly constipated. And so we tried to take care of the constipation with a lot of Miralax. She got so stressed from having to poop without being able to control it that she ended up having multiple seizures. And so what we discovered was that we had to go very, very slowly and gently with her to get her to a place where she could have bowel movements. I couldn't do it all at once because she will have seizures because it's such a stress response to having bowel movements, which have been so painful for her entire life. And so and this is all just what people have kind of guessed, is that there may be a factor of like some autistic children don't respond well to, I think, laxatives in general because it's something they can control and then they lose that control because we're now making them poop. And so it's hard to kind of tease apart what is what with that. In general, Miralax has been shown to be incredibly safe, but I will put the caveat that I have had 2 patients in my career and I have heard of very select few others, but there are some who don't feel like their children do well with Miralax. The beauty there is that we have other options. So for patients who Miralax is not an option, I am more than happy to try other things. The reason I like Miralax is that it's so easy to titrate a dose because what your child needs and what someone else's child needs, one might need 3/4 of a cap, one might need half a cap every other day, one might need 2 caps every day. And so it just varies, and it's very safe and easy to titrate that with Miralax, unlike some of the other medicines that we use.
Nasha has a question? While Ryan is walking over, what I just want to say is you could see the value in having a clinic, like having a Rett clinic. So, on our website, we have the FOXG1 Clinical Centers of Excellence, which are basically all the Rett clinics. So having a team, look it up. If you're in Colorado, travel to your team because really, it's having, multiple doctors looking at your children. From head to toe, our children experience something. So being able to tie GI to neurology is important.
I have a 2-part question. The first is for children that are on a medication for seizures, but sometimes have breakthrough seizures, like Amara, my daughter, is on Trileptal, but every once in a while she'll have a breakthrough seizure. Is it worth it to talk to our neurologist and push some of these newer medications like Snomabade or the new one from Longboard? I can't remember the name. And my second question is, are there any thoughts on VNS and other devices? For example, Amara's neurologist has suggested doing a brain implant. She has focal epilepsy. But also then caveated that with, I have only seen a few FOXG1 patients, so I'm not sure if it will work. So that's, doesn't make me feel that great. So just would want, love to know your thoughts on both.
I'll take the first part. So it's always a discussion with the family. What's important to you? Are you okay with if she has a few little brief ones just when she gets sick, versus balancing that of adding another medicine, increasing another medicine, and she has side effects? So I think that's the discussion. It's very family dependent about, what you want to push or not. I don't think it's unreasonable you should have the discussion one way or another with the treating team.
Yeah, absolutely. I think always the doctor should be aware that things are not, you're not at zero. And another thing about oxcarbazepine, it is focal, and I guess she is focal, but just to be careful that, some of the agents are less broad than others. So it's a focal agent. Sometimes that can be problematic. That needs to be maybe looked at, possibly an EEG for ruling out exacerbation. I'm just in case, right? And then, what was the second part? Oh, stimulation, yeah. So stimulation has a lot of different types, flavors, and so the most advanced would be RNS, or responsive neural stimulation, which I assume is what they were talking with you about. How old is Amara? 8. So a little bit on the young side. It's the most invasive because you have to put a device in the skull, which then it's actually kind of AI, it learns your seizure pattern, it can monitor them, it can count them, and then it's like a pacemaker in a way because it zaps when something is coming to sort of like try to stop it from happening, right? So it's actually very beautiful in terms of the idea of it. But she's a little small, probably. You want the skull to be like a certain maturity, but it's something to keep in mind if she's really focal. But I would say, how many meds has she been on before, or combinations, or just this? Then you're really just at the very beginning. The flow chart I showed you looked at, hey, your first choice, appropriately dosed, appropriately chosen, still it can be not getting us to zero, right? And then you think about the second thing. So certainly, she's still within the realm of consideration for oral med, because surgery at the end of the day is not reversible. It's totally appropriate for some cases, but you're in the very early stages, I would say. Yeah.
Thank you so much to our panel. We could sit here all day with you. I think we all want you on speed dial.